years, and today is no exception. So thank you to all of you, the thousands of you who have joined us today. We are coming to you live from several locations across the country, so we hope you will understand if we experience any technical hiccups. While continuing education credits are not available for the CPT webinar series, this is being recorded and it will be shared with you in the coming days. Additionally, if you'd like to download a PDF version of the slides, you may do so under the Resources tab, starting now or after the webinar. All right, before we get started, just a few disclaimers. Company names and logos cited in this presentation are only intended to demonstrate specific points and technologies. They are not an endorsement of any entity, product, or service by the AMA. Please note that the purpose of this webinar is informational only. You should consult a professional advisor for specific medical, legal, financial, or other advice. This webinar and CPT are copyrighted by the American Medical Association. Now, please take a moment to review the notice. All right, let's meet our presenters. Joining us today are three esteemed CPT experts who have led the efforts to streamline the E&M codes and guidelines and enable our understanding of how to implement the updates. Dr. Barbara Levy and Dr. Peter Holman are co-chairs of the AMA E&M work group, which developed the recommendations for these E&M updates that were then approved by the CPT editorial panel. Dr. Levy is the vice chair of the CPT editorial panel and a consultant working to improve women's health globally. She was the vice president of health policy at the American College of Obstetricians and Gynecologists for 7 years. Dr. Levy is a thoughtful leader with over 25 years of experience in direct care, research, and physician training in women's healthcare. She brings a depth of experience as a former member of the RBRBS Update Committee, which is known as the RUC, and serving for 6 years as the chair. She has practiced in leading initiatives in international and domestic health, corporate social responsibility, public health, public-private partnerships, government relations, and advocacy and policy development. Much of her personal and professional experience has focused on improving the health, well-being, and livelihood of women across the United States and globally. Dr. Holman is the Chief Medical Officer for Brown Medicine, the practice group of the Brown University Warren Alpert School of Medicine. Until 2015, he was the Associate Chief Medical Officer of Blue Cross Blue Shield of Rhode Island and ran a 3-person primary care practice. He currently has a part-time geriatric primary care practice in Rhode Island. He has over 30 years of experience in medical management, including as a medical director of an HMO with a Medicare product, a Medicaid plan, and commercial PPO. He has been a medical director of long-term care hospital, nursing home, and home care. He is the past chair of the American Geriatric Society Public Policy Committee and is currently the AGS board chair. He is also past chair of the CPT editorial panel and is currently the vice chair of the RUC. Finally, we will hear from the AMA's Leslie Prelwitz. Leslie is the Director of CPT Content Management and Development. Leslie's work focuses on setting the strategic direction for publishing and maintenance of CPT content, as well as serving as the Secretary to the CPT Assistant Editorial Board. She provides advice on the proper use and application of CPT to key stakeholders, including educational content presented in CPT Assistant and the clinical examples in radiology. Certified in both CPT and ICD-10, Leslie has over 25 years of coding experience in healthcare management, coding analytics, and consulting. Now, many of you are familiar with the AMA, but because of our extensive audience today, we'll just take a moment to ground everyone in the broader work of the organization. We are a 176-year-old mission-based organization with a long-standing mission to promote the art and science of medicine and the betterment of public health. And while the work of the AMA is far-reaching and broad, in summary, the AMA is the physician's powerful ally with a focus in 4 key areas, which are all underpinned and underscored by innovation, equity, and advocacy. The AMA, as the physician's powerful ally, represent all physicians with a unified voice, and you see this through our work in policy and advocacy. Importantly, we work to remove obstacles that interfere in patient care and reducing the burden to help physicians. We want to allow them to get back to what they really went into the practice of medicine to do, care for their patients. We lead the charge on the public health crises, and you may recognize our work in this area through important initiatives to eliminate health inequities and in areas supporting chronic disease, hypertension, the opioid crisis, and of course, the recent pandemic. Finally, we support the future of innovation in healthcare. As new technologies continue to emerge, we work to ensure that technology is an asset and not a burden or just one more thing for a physician to do. Now, our work with the CPT code set supports the AMA's mission to reduce burden on clinicians and remove obstacles that interfere with patient care. As many of you know, the E&M codes represent a substantial portion of care provided to patients, and they're crucial to maintaining the efficiency and productivity for clinicians. The 2021 overhaul of the E&M office visit codes was an effort to simplify E&M coding and documentation and to reduce overall physician burden. The revisions that went into effect this year seek to provide continuity across all of the E&M sections and allowing the revisions implemented in the office visit sections to extend to all of the other E&M sections. All right, here's our agenda for the day. First, we'll hear from Drs. Levy and Holman, and they will review the 2023 revisions and the 2023 technical corrections. They'll take some time to walk us through case studies curated to align with the feedback we've received. And then Dr. Levy and Holman will provide insights on CMS's final rule for 2023 and the AMA's response to it. Leslie will then highlight a variety of resources that are available and designed to further support your use of the E&M codes, and we'll conclude with a Q&A session where we will get to as many questions as we can. All right, just one housekeeping thing. Please remember that the recording of this webinar will be available on demand within the next week, and you can download a PDF of the slides from the Resources tab. And now it is my pleasure to turn over the presentation to Drs. Levy and Holman.
Great, and I'll add my welcome and my thanks to the AMA for supporting us in all of this really important work. So first, we're going to go over just what happened for 2023 and to remind everyone what the purpose of all of this work was. It was really to reduce burden on physicians and qualified healthcare professionals as we were documenting and coding our work. So we wanted to decrease the need for audits, to decrease unnecessary documentation that wasn't related specifically to the patient encounter and to patient care, and then to ensure, hopefully, that the payment for E&M was resource-based and that we had no direct purpose in trying to reallocate resources across the specialties. So the notable changes were that all of the codes now throughout the E&M section that used history, examination, and medical decision-making for choosing correct level of service now just use medical decision-making or total time on the data they encounter. They do include a medically appropriate history and or examination, but no bullets that allocate how many of this or that system that we asked about or that we did. Time still does not apply for the codes in the emergency department set. We merged the hospital inpatient services and the hospital observation services into a single set of codes. Medicare still requires office codes for consultants when the patient is in observation care. However, the physician or qualified healthcare professional work associated with a patient in observation care or inpatient care was determined to be the same, and so we merged those. We also merged home service and domiciliary care services. We aligned the admission codes with current usage so that they are now initial services, and initial services can be reported by more than one physician or qualified healthcare professional during a specific admission if they come from different practices or different specialties. And then CPT allowed reporting of more than one E&M service on a single date when those services are performed in disparate settings. So office to hospital, emergency department to hospital, and we'll have a case that goes over that. Of note, however, CMS, at least at this point, does not accept multiple E&M codes reported on the same date. And we'll go over that just a little bit more as well on the case. So this was a comprehensive restructure. What we did was add some corrections and some clarifying guidelines. So when you order a test, but it's considered, but you don't do it, and you discuss that, that counts. We made some minor editorial revisions to the MDM table to add some clarifications. We clarified what activities cannot be used to count in total time, and that is specifically time spent in the performance of services that are otherwise reported. So as an example, as an OBGYN, if I perform an ultrasound and I report that separately, the time that I spent to counsel the patient about that ultrasound and perform the ultrasound cannot count towards total time for the E&M service. Travel to and from also cannot count for the services. We also added some guidelines clarifying concepts like analyzing a test, defining a unique test, discussion regarding an interactive exchange between qualified healthcare professionals, and reporting a combination of data elements. So these are all things that we clarified in the language to help us. So the update to medical decision-making table, and Peter, I think I'll let you go over this one a little bit so that we can describe what we mean by a stable acute illness and what we mean by some of these things in the MDM table.
Sure. Thanks very much. And I, too, would like to add my welcome to everybody for joining us today. So when we expanded the rules for medical decision-making across new types of services such as hospital, observation care, nursing facility, et cetera, it turned out that there were probably some additional definitions that were warranted, and that's what we did. So at this low level, you'll see that there's a new definition that is called stable acute illness, and we'll get there in a second. There we go.
Yeah, there we go.
And basically, consider a patient that's admitted to the hospital. Obviously, if you're being admitted, it's for something that's pretty significant. If you're at least the attending physician treating that condition. But after a few days, the condition may now have stabilized. Now, maybe the person is still at a hospital level of care, so there really was a need to have a stable acute illness where you're just completing treatment. It also could occur in the outpatient setting, though. That does happen where you've got people that are coming back for follow-up services. So that's an area that we felt was necessary. And then there's also people that are at inpatient or observation level of care where the condition is pretty minor. And so we wanted to create a category for that where the condition is such that it is not not really beyond a low level type of problem addressed, but yet it did require them to be at the level of inpatient or observation care. So that was a new definition there. And I guess I can advance it to the next slide. Do you want me to keep going, Dr. Levy? Great. So then the other things that we addressed that were minor changes were that now people said, like, well, you already had in this high-risk area the decision for hospitalization. What if they're already in the hospital? And we wanted to make it clear that it wasn't just staying another day was meaningful, but no, if you were thinking that they might need to go to the intensive care unit or something like that, that would count. And then finally, there was a suggestion at the CPT editorial panel meeting that we add parenteral controlled substances. So those were the changes that were made to the medical decision.
And we'll have a case. We'll have a case to talk about some of these things to add some clarity. So again, this is just a summary. We updated the introductory guidelines. We deleted the hospital observation services, and that was combined now with hospital inpatient or observation services. Consultation E&M codes, some were deleted, some were revised. We revised the emergency department services. the nursing facility services. We combined domiciliary and rest home services into the home and resident services. So there were deletions and revisions to all of those things that you should take a look at. And then this is just a high-level summary of all of those things that have changed, and I won't read through all of those things, but this just tells you where all of those things happened. For consultations, what we did was retain the consultation codes with some minor editorial revisions to the descriptors. We tried to delete confusing guidelines, including what was the definition of a transfer of care versus a consultation. The lowest level of service for both inpatient consultation codes was deleted in order to align with the 4 levels of MDM and all the other E&M services. So some payers consider consultation codes a status of I. They don't pay for those, in which case we recommend that people use the inpatient and observation or office visit codes depending on the place of service and the status of the patient. So we anticipate that CMS would not recognize the consultation codes, but there were several payers who did, and people on the E&M work group suggested that for that reason, we should not eliminate those. For the emergency department services, we maintained the existing principle that time cannot be used for code level selection. There were some editorial revisions to descriptors to reflect the code structure that had been approved for office visit. The MDM levels were modified to align again, and then we maintained the CPT code numbers so that it wouldn't be terribly confusing for everybody. So, and we articulated some current practice that was not explicit in the CPT code set, and you can read all that. So I'm going to turn this over now to Dr. Holman.
Thanks a lot. And I'm going to cover the nursing facility services, but I also want to just comment on a couple of things that we went by pretty quickly. So in the emergency department, because we kept the same code numbers, but changed the levels to match sort of the office visits, with the exception of the highest level code, the numbers and the former MDM level don't match anymore. So pay close attention to that. I think probably everybody
define for you what a technical correction is. It's clarification of an original panel intent for the current code structure. So here's where you can find those on the website. And what did we do here? We looked at independent interpretation and appropriate source. So we revised these definitions to make them more clear. An independent interpretation of a test is a test that's ordered, and then I go down and I look at the films myself, and I independently interpret them separate and apart, as an example from a radiologist. Under those circumstances, both ordering the test and that extra effort and medical decision-making that went into my independent interpretation of that test may also be used. So this is actually longstanding guidance, but there were a lot of questions about it, so we made that clarification. We also clarified what an appropriate source is. So there are times when pediatricians, for example, will get information from school, from a psychologist, from someone that is not a qualified healthcare professional, but we do review those documents and they are considered in the medical decision-making for the care of a patient. So we explicitly now state that those types of documents that are reviewed are appropriate to the care and are included in the medical decision-making risk table. And so now I think we'll go on to some case studies.
And I'll go ahead and give an overview to those. And oh, by the way, Dr. Levy, when we were talking about qualified healthcare professionals and psychologists, we're talking about school psychologists that may not be independently licensed. Of course, psychologists, I hope there may be some on the line.
Yes.
We know that you are qualified healthcare professionals in terms of being able to report services independently. So these are topics that we thought warranted some case studies based upon questions that people have been getting at CPT Assistant and the information services folks there. So the first thing is we wanted to talk about this hospitalization, escalation of hospital level of care, that calculation of risk that we briefly addressed. We're going to go into a little more detail, as Dr. Levy mentioned, with a case example on multiple E&M visits on the same date of service and how you might report those. We'll talk about prescription drug management, specifically on the inpatient setting, where there are daily visits as compared to visits separated by weeks or months or a year. And we'll address details about parenteral controlled substances, and I'll talk a little bit about the skilled nursing facility, multimorbidities, question that was touched upon a little bit before. So Dr. Levy, take us through our first case, please.
Okay, this one's a little bit complicated, so bear with me. But we have a 41-year-old female with a known history of uterine fibroids who presents with severe abdominal pain, vomiting, nausea, progressively worsening. She calls the gynecologist that she's been established with, who meets the patient in the emergency department. On exam, she has a low-grade fever. She has a diffuse tenderness with guarding. Pelvic exam shows no additional findings to what they've noted before. Some tests are ordered, including a pregnancy test that's negative, some x-rays, urinalysis, all of which is normal. So the patient is treated in the emergency department with IV fluids, with some hydromorphone and ondansetron to try to get her nausea, vomiting, and pain under control. But after some observation in the ED, it's clear that the patient could not be treated for less than an observation status, and the decision was made to admit her to the hospital. So on the date of admission, the gynecologist sees the patient additionally for 45 minutes on the inpatient floor. The ED test results are documented in her admission record. In addition, ultrasound and CT scans of the abdomen are ordered, and the medications are continued. On day 2, the test results show ascites and numerous uterine fibroids, and there's a decision made for surgery. Patient undergoes exploratory laparoscopy, at which point extensive endometriosis and a torsed necrotic fibroid is removed, and then the patient is discharged home. So lots of stuff to unpack in this particular case. We're talking about the risk, the high risk of morbidity, additional testing, and reporting more than one E&M visit. So some questions for this. How is the decision regarding hospitalization or escalation of hospital level of care incorporated into the evaluation of the E&M level, and where is it incorporated? Can more than one E&M visit be reported? What codes does the gynecologist use? And then what do we use for the additional services provided? So there are a couple of ways that this can play out. For CPT, the gynecologist could have used 99214 or potentially time to report the services in the emergency department. Or, as on this slide, the 99284, which is an emergency department visit. If the gynecologist is reporting the emergency department visit, then the level of medical decision making is moderate. So there's one undiagnosed new problem with an uncertain prognosis. The amount of data and complexity of the data is moderate. And there was no particular discussion, and the risk is high. So remember that you need 2 out of 3 the elements. So this would be a moderate level of medical decision making, and the physician can use this particular code. For the hospital, now the decision making that happened in the emergency room may not be counted towards the level of code selection for what happens at the inpatient initial visit. So for this, it is a 99222 based on the medical decision making. So moderate level of medical decision making, low amount and complexity of data because most of the data was accomplished in the emergency department. However, 2 unique tests were ordered, the CT scan and the ultrasound, whose results were not available yet on that initial visit. And then moderate risk of morbidity and mortality for the patient management. So the decision, again, for hospitalization or escalation was made in the ED. The medications are just continued. So you had to write new orders, but there's no new decisions with respect to the medications. Gynecologist is considering whether surgery or more urgent intervention is needed. The controlled substances are not being cautiously titrated, and we're going to go over this in another study, so it's really not high risk. This is overall moderate risk for this case study. So how do we do this? Again, there are 2 ways. For CPT, the gynecologist could report the emergency department visit using the emergency department codes, remembering that you must use medical decision making. You cannot use time if you're reporting an emergency department visit with a modifier 25, and then report the additional initial hospital visit at a moderate level of medical decision making. Prior to 2023, that would be considered a single visit. It would be coded at the highest level, which would be at the hospital initial visit level. Now, if you're using one code, and this would be true if this were a Medicare patient as well for CMS, you may use the time spent in the emergency department and the time spent on the floor accumulated together for total time on the date of the encounter when you are only reporting the hospital initial visit code. So again, 2 ways to report this. CPT says you may do it with an ED visit, a 25 modifier, and an initial hospital visit. For CMS, this would be a single code reported as the initial hospital visit, but you may include all of the time and medical decision-making that went into the emergency department visit. I hope we've made that pretty clear as mud.
I understand.
So here's a more graphic way of saying this. You could do ED visit and hospital observation. This would be a similar scenario if this patient had been evaluated in my office, and then a decision was made to send her directly to admission to the hospital, inpatient or observation. The sequencing of tests might be a little bit different. And you could also report an ED service using the outpatient codes if you chose, rather than the ED codes. So lots of alternatives and options for this particular scenario, and all of which could be correct. So, prescription drug management, Dr. Holman.
I'll do this one. But I want to really thank you for taking the gynecological case because, you are the gynecologist and I'm the geriatrician. And I thank God there wasn't a maternity case here because I have never felt comfortable being in the same room with a near-term woman because I was afraid I might have to immediately call a cab driver to do a delivery since they've probably done more than I have. So let's go over prescription drug management in the inpatient setting. And there's no cab drivers anymore, so that's really tough. Okay, this is a typical patient that we see quite commonly, a 60-year-old male with hypertension, diabetes, hyperlipidemia, who has chest pain, et cetera, et cetera. They have a past history of a CABG and they're admitted with a diagnosis of unstable angina. So first thing you're going to do on day one is you're going to change the medications to include antiplatelet therapy, aspirin, and clopidogrel. Now, the same physicians seeing the person on days 2 and 3, of course, reviewed the medications as you would do every day on the inpatient setting. And on day 4, adjustments were made to the hypertension and diabetes medications. And on day 5, changes were made to the anti-lipid medications. The statin dose was increased, high-intensity statin therapy. So here, when we talk about prescription drug management, that is something that is on the risk level. What level of risk do we have here when the meds were obviously reviewed each and every day? And our feeling is that, and as we've taught in the outpatient setting, that simply reviewing the medications in the sense that you acknowledge that they're being taken. So in other words, you're basically doing medication reconciliation isn't sufficient to be called prescription drug management. We're fairly broad in other things that would be prescription drug management, but we would expect it to be more than a review. So for example, if you do address the risk levels, if you do address the relevance to the plan, et cetera, that would be pretty clear. It doesn't necessarily have to be that you change the medication is what we've taught, but it does have to be addressed more than simply clicking a box that you're noting that the meds are being continued or reviewed. And in the inpatient setting, most of these meds that were mentioned here would not have to be reordered on a daily basis. All right, case study number 3.
Parenteral controlled substances, one of our favorite topics because it gets a little confusing. So another very common scenario, 65-year-old male who has a history of type 2 diabetes, chronic obstructive pulmonary disease, and hypertension is an inpatient. So the patient's seen by the internal medicine hospitalist after a major abdominal surgery, and the patient's now experiencing an exacerbation of a COPD and difficulty breathing. So the primary care physician notes are reviewed, CBC is ordered, chest x-ray, BMP. IV hydromorphone is prescribed for the postoperative pain. Pain is increased, especially when the patient has elevated task of breathing. The hospitalist observes the first dose, returns 30 minutes later to check the pulse ox and the respirations, and this is the second date of service by the hospital during the stay. So when reporting the inpatient E&M visit for subsequent days in the area of risk, are parenteral controlled substances a factor for each patient day or only on the day that they are prescribed? This is a common question. So subsequent hospital inpatient or observation care is 9923X, X meaning determine the level. For this patient, the number and complexity of problems addressed is high. The amount or complexity of data to reviewed and analyzed is moderate. So there were some tests that were done, but the risk of morbidity or mortality of our treatment for this patient is high. This patient has COPD, is at very high risk with the use of IV narcotics. And in this scenario, considering that in medical decision-making as high risk makes sense. For my patient who's on a PCA post-cesarean birth, I'll make this a pregnancy one, Dr. Holman,
okay.
Who's on a PCA, healthy patient who's going to, get up and around within 24 hours. In that scenario, IV parenteral medication would not be considered the same high-risk scenario as this patient. So one of the reasons that we did not give a lot of examples in the MDM table of risk was because these things are patient-specific. The level of risk varies by the underlying condition of the patient and the scenario in which a physician or qualified healthcare professional is making these decisions. And that's a really important point for all of this, that these are decisions and clinical judgments that are made in very disparate kinds of circumstances. And so there isn't a black and white answer that IV parenteral narcotics are always high risk, because it's really not the case.
Right.
So again, the patient has to be seen and assessed daily with some documentation in the record of that medical decision-making related to the continuation, discontinuation, or adjustment of the parenteral controlled substances for this risk to be counted on subsequent days. And in this case, clearly, that makes sense.
Yeah, and you talked about the risk the way any honest clinician would interpret it. Your PCA, you might have renewed it for a second day, probably not for that particular patient who could have gone home earlier. But if it's the type of thing that it's a PCA or it's PRN, and even if you renew it on a second day, that's really not a significant consideration because there's not much risk. That would be prescription drug management potentially, but not necessarily high risk. So it's interesting. I misunderstood this case originally as parenteral control and not parental control and not parenteral controlled substances. So I was going to ask my son about it, but I never had any control over him, so it wasn't really going to be too successful. So let's go ahead and go on to, I blew that joke badly, sorry. Let's go on to the skilled nursing facility medical decision-making scenario. And, I think one of the things that's interesting is you'll notice that we talked about you can't review the same data twice. We talked about making sure that the risk is taken on a day-by-day basis on the inpatient setting. But you'll notice the problem addressed may be the same throughout because it's the patient's condition isn't necessarily going to change. It may more matter whether you're a consultant or whether you're taking care of the patient as the attending, or, of course, the patient may have different complications develop during their stay. Well, this is a person who's now coming to the skilled nursing facility. She has a 84-year-old female who just underwent a TAVR or TAVI, if that's the term you prefer, a catheter aortic valve replacement, and is going for cardiac rehab and management. They had, of course, chronic congestive heart failure and had to be titrated and treated while they were in the inpatient setting. And they also suffered mild acute kidney injury and deconditioning, and that's why they're going to go to the skilled nursing facility rather than home. The cardiologist needs to continue to follow this patient post-operatively, post-procedurally, I guess, and the patient is transported to the cardiologist's office for follow-up. And there, the cardiologist orders labs, makes adjustments to the medication, considering both the AKI and the CHF, and also knowing that they're going to be getting lots of rehab services, and asks for the results of that to be reported back to the cardiologist, the labs, and how the patient's doing, their weights, their vital signs, and their overall global health. So naturally, the cardiologist knows this is a patient with multiple morbidities that is being managed and is going to have lots of medication changes, et cetera, in the ensuing days to weeks. So they report 99306. So is that correct? And the answer is no, it's not correct. So why isn't it correct? Nice try, though. And actually, it could be correct, but we'll go over why it would be correct, not because of the multiple morbidities. The logic is the issue there. So they were seen in the office, first of all. So it would be an office visit code. So it definitely wouldn't be correct to report a nursing facility code. It would be 99, this patient must be established, 99212, clearly not that one. 99214, 99215 would be the likely codes that one would be reporting. The multiple comorbidities and intensive treatment changes is a service that, as I said, is only allowed for the attending physician in the nursing facility, and it's only allowed on the initial visit. The MDM level on this one appears to be moderate. This is a tough one when we're talking about exacerbations, but this is a person who had an exacerbation of their condition. They're now more stable. So I think it's a chronic illness with exacerbation, progression, and side effects of treatment or treatment changes. It probably doesn't appear to be severe at this point. They're stabilized, but we couldn't call all their conditions stable. In other words, they're not at their treatment goal, or the cardiologist wouldn't be making a lot of changes. And so 99214 probably is the most appropriate code for the cardiologist to report, unless they were using time. Now, What about the doctor back at the nursing home? So that physician on admission would have reported 99306 for this patient because they are managing all those problems, even though the cardiologist is going to be participating in the co-management of that patient. At least in Rhode Island, traditionally, I'm not sure if this is the case everywhere, even if an expert cardiologist writes an order, they still call up the attending physician and make you validate and verify the order because you're the one that's responsible for the overall care of the patient. Keep in mind that when that principal physician or a member of their team goes back to care for the patient in a subsequent care visit, even though the person may still be getting all these different things done, they no longer can use this code. They will simply use the standard MDM schedule in terms of the complexity of the problem addressed and the risk of patients and the data reviewed.
Great. So now we'll talk just a little bit about CPT responses to the CMS final rule for 2023. So these were changes that were accepted at the February 2023 panel meeting. Once again, we were trying to provide consistency with CMS rules, and we're trying to reduce that administrative burden on practices. So we revised the times for codes 99202 to 205 and 99212 to 215. We also revised the times for codes 99306 and 99308. We revised the introductory guidelines for split or shared visits to create some new definitions that were more commensurate with team-based care and how care is actually delivered. We talked about what we've gone over in great detail already here today, which was the multiple E&M visits on the same date. And then we talked about and we revised hospital inpatient or observation care services, including admission and discharge services on the same day. We created a table for that just to make it more accessible to people and more understandable. Big red flag here. These things are effective January 1 of 2024. They are not currently in play.
Yes, so, they're not. I'm sorry, Dr. Levy.
Go ahead.
Yeah, they're not technical corrections is the key thing. Even though we have taught in some ways, even in today, about how you might report different services, they are not technical corrections.
Yeah. So the things we did were remove the time ranges from the office or other outpatient visit codes, following the format for other E&M codes for time. So there's a threshold time that must be met or exceeded for each level of service, but it's not a range. We defined what the substantive portion of a split or shared visit is, and we defined it both by either time or medical decision-making consistent with what we've done throughout the E&M services. But it's very clear that in team-based care, there are situations in which the visits and the reporting is split among members of the team. And the medical decision-making, though, may be ultimately responsible for one person. So those things were defined and carefully written into the guidelines. And then we established some reporting instructions for care services where admission and discharge are done on the same day. And when that stay crosses over to calendar dates, which was also very confusing to people. And we tried to make a distinction there to make it a little bit more understandable. And Dr. Pullman, I'll let you go on the next one.
Great, thank you. Yeah, on that last item, we essentially put what our CMS rules and what they did put in their final rule for this year. So Dr. Levy's already really covered split and shared visits quite well. You know, this is when you have both a physician and then a non-physician professional caring for the patient at the same time. And this is for facility services only. This is not incident to in the office setting. So, and these are really more Medicare concepts. These are not CPT concepts, but CPT was asked to address this, and so CPT responded. So the House of Medicine feels that medical decision-making should always be a part of determining who reports the service. Why do you care? Well, non-physicians get 85% of the physician fee schedule. Physicians get 100% of the physician fee schedule. Medicare has said they want it to be who spends the most time on the care of the patient on a total time of the date of the encounter. So it's not even who spent the most time with the patient, it's just who spent the most total time on the date of the encounter. House of Medicine disagrees. We wrote up what we hope is a good rationale basis for allowing medical decision making to be part of it in CPT. We'll see how CMS responds. Well, hopefully they will accept what CPT has written for 2024. We also had, as we mentioned, and we had a case about how do you handle multiple evaluation management services on the same date. So we wrote up a bunch of different things addressing, questions that are longstanding of many, many years. What about 2 visits in the inpatient setting? How do you address those when it says it's per day codes? We allowed things that Medicare has always allowed, such as a discharge from the hospital and nursing home admission on the same day. That's always been the case. We talk about transfers in hospitals, et cetera, et cetera. And most importantly, we basically say if you can only report one service, you can at least count the time on the total time of the day of the encounter, which has been the reason. So those are things you can see in more detail. Again, they'll be in CPT 2024, and we'll see if there's any comments in the proposed rule that will come out in July. And the last item is that Medicare had commented in the final rule and in the proposed rule for the 2023 fee schedule that they thought the times in some of the nursing facility codes were probably rounded improperly based upon the RUC survey times. And the times that we had chosen were sort of to create a scale, kind of like was done in the office visits, where it was easy to remember 10, 20, 30, 40, 15, 30, 45, 60. So we tried to do that, but it really didn't match up quite as well. And we concurred ultimately with CMS that probably we should use the rounding as one would typically do, up or down the closest number. And that'll be in 2024. So the times have not changed yet. So this is one that's very important, even though it's already been approved. Use the times that are in CPT today. Medicare did not have such a major objection that they changed the times or created G codes. And looking ahead to 2025, we're going to do telemedicine. So there have been codes that have been approved by CPT and are going through the RUC process for audio, video, and audio only, new and established patients, and deletion of the telephone codes. We'll see how that goes, but that's for 2025 because it has to go through the whole process of rulemaking and is not something that is it has to have all the RUC work done before it can be in effect. So I'm going to turn it over to Leslie Prowitz.
And thank you, Dr. Homan and Levy. Certainly an action-packed session today, lots of information. I just wanted to make sure that people were aware of a couple of the resources that we have available for you at the AMA to help facilitate your use of the codes and keep up on everything that is currently on and will be coming through. So I'll walk through a couple of items. First, if you've gotten your 2023 code, professional code book this year, you notice we've added the addition of the E&M Companion. This was specifically done to kind of mine some of the pearls of the changes in the 2023 code set, so you don't have to. So a lot of the highlights that we gave are already in that publication, code consolidations, revisions, deletions, reporting considerations, and summaries, so you have them for quick reference in the moment when you need those to be available to you. Additionally, we've had some additional courses come through on our EdHub site. And as many of you know from firsthand experience, the EdHub learning platform really helps to bring together education from the AMA and other trusted sources. They're designed to support lifelong learning, licensure, certification needs for physicians and other medical professionals to stay current and continuously improve the care they provide. In this particular example, we've done a lot around specifically looking at the 2021 changes and how those guidelines can help practices represent the increased time and complexity of medical decision-making associated with social risk. Social determinants of health was a very visible change in the 2021 changes, and with 2023, with the MDM table being expanded to different care settings, there could definitely be some additional learnings for many of you who may not have looked at the outpatient setting before. So definitely take advantage of the EdHub site. Lots of great content placed there in terms of the modules. We can get you information on how to access that after this webcast. In addition, with all of the questions that we've received today, another area of resource for you is to remember that we do have our CPT knowledge base. And this allows you to actually search expert explanations from the CPT Assistant Editorial Board, prepared by our expert CPT Information Services staff, seasoned expert coders who actually dive into the deep nuances of CPT to bring you responses that are uniform and trusted resources, and also can combine with medical specialties when necessary and other resources that are used actually in the creation of the code. So this is a group that is there when the codes are made. So all the details and rationale is what we put into those answers, and that's available for you to do a deep dive in case you see that question that you have someone already asked it. May be available to you there. We also place there knowledge base exclusive content that you may not find in other AMA resources and publications, sort of our staff picks of common questions we have there available for you. And for the E&M section in particular, we have actually created a subsite solely focused on E&M 2023. And it goes beyond what you saw in the E&M companion contents. It's our way of having a very dynamic source of E&M questions and answers, including probably some of the hundreds that we won't be able to answer today, but they may show up on that site. So you may find other places where that's noted. The knowledge base also gives you an opportunity to submit your own questions to CPT experts for response if needed. Additionally, CPT Assistant, certainly that is the official resource for CPT coding education and guidance for past, present, and future code set releases, been around for a little over 30 years. Many of you are familiar with that, certainly our FAQs, anatomical procedural illustrations, graphs, and charts with expert insight from our CPT Assistant editorial board. In terms of E&M, this is only a partial listing of all of the entries we've already made in that newsletter. It is a monthly newsletter relating to E&M 2023, including both feature articles and questions and answers that show up in almost every issue. And we will certainly be continuing that as we hear more from you about additional areas where guidance and clarity is needed. So that's why we're here. So we've covered quite a bit today, the refresher, the technical corrections, feedback, case studies, final rules and CPT responses, as well as AMA resources to keep you on track. And I believe, Lori, it is time for questions and answers with the 3 or 4 minutes we have remaining.
Well, we won't be able to get to many questions. So really terrific material covered today. And thank you very much to all three of our presenters for such a rich presentation. I will try and get through a couple, and there are many questions, so thank you all. I'll try and get to a couple. So first one for Dr. Levy, when billing by time, what can be included as preparing to see the patient?
Right, so preparing to see the patient includes reviewing the old chart, reviewing tests, obtaining or reviewing separately obtained history from outside sources, again, performing the medically appropriate exam or evaluation, but that's during the visit. So the preparation is really review of records, review of old tests, consultation or discussion with outside folks that may contribute to seeing the patient. What cannot be counted is other services, as we talked about earlier, that are separately reported, but also travel. We've got a lot of questions about the teaching scenario. So teaching that's general and not limited to discussion about a particular and specific patient cannot be counted towards the time on the date of the encounter either. If that teaching and discussion is specific to the patient and in preparation to see the patient, then it can be counted.
Thank you very much, Dr. Levy. I'm going to do one more question because I see a theme that many people are asking about this. And Dr. Holman, if you could address, if a patient presents with more than one acute, uncomplicated illness, will noting more than one increase the MDM level for problems addressed from low to moderate? Some of the MACs have discussed it, but it would be wonderful if you could address this from the perspective of creating this MDM table. Thank you.
Thanks. Yeah, we had a long discussion on this very specific issue as we first created the MDM table. And there were people that wanted to say, well, 2 stable problems is a moderate, so 4 stable problems must be high. And they basically just wanted to do math. And that's not what was determined by the work group, not what was supported by the editorial panel. So you have to go by what is there. It's one or more, two or more, those types of things. And I think on some of the ones it even says one or two. So look at what is there. You can't add up.
Yeah, more is not necessarily higher medical decision making. So if somebody has a sore throat and an earache, that doesn't rise to the level of moderate medical decision making.
Thank you very much. All right. I think we're about at the end of our time. If you have enjoyed today's webinar, then you might consider attending the virtual CPT RBRBS 2024 annual symposium. We will be opening up registrations in July, so please mark your calendar. It will be held on November 15th through the 17th. We have already talked about some of the resources that the AMA has. I'm going to go quickly past the slide, but you will get this when you get the copy of the presentation. The AMA obviously has a wide variety of resources that are available to you, and we would be also pleased to have you access and use. And then before we close, just a couple of things. There will be a brief survey at the end of this. We very much appreciate your